feeling sleepy after lunch. What I am going to present here is a brief introduction regarding physics, mainly regarding the physics of radiology, which is something like a short note, not in the question form, a brief outline, but within that you will get important points which may be asked in question form and followed by that question proper. Probably half of the topic can be covered today and remaining half can be taken in another class. So main points to be remembered: year of discovery of X-rays. Here is 1895, November 8th. When William Conrad Roentgen was doing experiments using a vacuum tube, he found that some materials with fluorescent property. Fluorescent property means that emits light when X-rays or ionizing radiations falls on it. So these materials were showing blue. So he presumed that there are some invisible rays, and he called it X-rays, X undiagnosed. He got Nobel Prize for that. The points to be remembered is how X-rays are produced. And if the question is on mode of production of X-rays, X-rays are produced when fast moving electrons are suddenly stopped by anode. See, when a bulb glows, when a filament glows, an electron cloud is formed around that filament. Electron leaves the filament and come back to that filament. When we apply a very strong potential, or when we try to attract these electrons by applying a very strong potential, kilovolts, then these electrons will leave the filament, then they will move towards the anode. So filament is on the cathode side and there is another thing called anode on the other side. One point which you can take down is, in the present day X-ray tubes, it is rotating anodes. In the initial phase of discovery of X-ray, it was static anodes. Even now, therapeutic X-ray tubes are using static anodes, but diagnostic X-ray tubes are using rotating anode. And one more important point to be noted is, speed of rotation of anode is 3000 revolutions per minute, 3000 RPM, revolutions per minute. And then these electrons which are occurred at very high velocity are suddenly stopped by the anode, or in the anode, X-rays are produced. Another one is known as characteristic radiation. Just note down 2 points. Now we will go to the detail. One is Bremsstrahlung radiation. They are X-rays emitted by sudden stoppage of the cathode, sudden stoppage of the electrons by the anode. Characteristic radiation will differ. Its characters will differ depending on the anode material. Anode used in X-ray tube is tungsten. You can note down that point. Anode used in X-ray tube is tungsten. Anode is presently anode is rotating anode and speed of rotation is 3000 RPM. X-ray used in radiography. You have to mug up. It is photoelectric effect. Property of X-ray used in radiography. Radiography. Photoelectric effect, and like light ray, it is what a photographic effect also. So it's photographic effect on the X-ray film makes the latent image visible. So X-rays are ionizing radiations. So once again, X-rays discovered by William Bernard Ronson. Year is 1895, November 8th, and got Nobel Prize. X-rays are produced when fast-flowing electrons are suddenly stopped by ion out. Property of X-rays useful in radiography are photoelectric effect and its photographic effect. X-rays are ionizing radiations. So that is the first radiograph in the history of medicine, that of handled to wedding ring, that of Mrs. Ronson. CT scan, year of invention 1972. And by the physicist, name is Hounsfield. Discovery credit goes to Hounsfield. He got Nobel Prize for that. The mode of image production is different. In X-rays, it is the photographic effect on the film. In CT scan, primary there is no film. Film is in the last stage after the image is produced. So, the X-ray tube is there. In between you have patient, and the X-rays pass through the patient, and these rays fall on a set of detectors on the opposite side of the patient. When it has seen X-ray, CT scan gantry move the X-ray tube and the detectors revolve around the patient. That way, it helps to take sections, tomogram, CAT scan, computerized axial tomography scan. That is the original name, initial name, CAT scan. Now it is simply known as CT scan, computerized tomographic scan. Not only axial, coronary, solitary, etc. are also possible. Different tissues of our body attenuate X-rays in different manner. This difference in attenuation can be picked up by the detectors, X-ray detectors that are kept across the X-ray tube or on the opposite side of the patient. If the X-ray tube is in the front side, detectors are on the opposite side, back side. When the tube rotates at one stage, extreme may be in the posterior side, detectors comes in the anterior side. So different tissues and organs attenuate X-rays in different ways, and this difference can be picked up by the X-ray detectors. X-ray detectors are certain crystals which emit light, or certain crystals when this light is again converted back to electrical energy. And it can be calculated, the information obtained from this can be fed to the computer, and the rest is done by the computer. So we have an X-ray source and X-ray detectors. There is in the history of CT scan, there is first generation CT scan, second generation CT scan, third generation, then came spiral CT. Then came electron gun CT or ultra fast CT or cardiac CT. You can note down that cardiac CT, ultra fast CT or electron gun CT. Then this particular machine is used only for cardiac CT, cardiac scanning. But because of technical reason, now it is not in use. Now present CT scans are in the group known as multi-slice CT. specialized CT. The number detector crystals, the X-ray detector crystals used in CT scan are bismuth, xaminate, many things are there. Cadmium tungstate, xenon, a gas but it's a xenon gas, it's a radioactive, xenon 1, 2 to 3 is used for ventilation scanning. You know, ventilation perfusion, mismatch, the pulmonary thromboembolism, etc. Xenon 133 is a radioactive xenon which is used for ventilation scanning. Otherwise, xenon is an inert gas. And sodium iodide. So detectors in CT scan are bismuth, xaminate, cadmium tungstate, xenon, sodium iodide, etc. The principle of MRI is nuclear magnetic resonance. Charged particles with movement. We have a magnetic property. That is the basic thing. So when nuclei with unpaired electrons, 1, 3, 5, 7, like that. So these protons will be spinning. Best example is our body, 70% is water, so H2O. So in the routine MR, hydrogen ions are used for routine MR imaging. Phosphorus MR is there, but not widely used. Practically, the whole MR scanning is making use of hydrogen ions. Hydrogen ions. So these hydrogen ions, when they have a nuclear magnetic effect. So they act as nuclear magnet. But in effect, practically there is no net magnetization in our body because these nuclei are randomly oriented. If one is in one direction, there will be another in opposite direction cancelling each other, and the net magnetization is zero. But when our body is kept in a very strong magnetic field, some of the nuclear magnets align along the field and some will align directly in the opposite way. And this is not equal. There is some inequality between the number of nuclei that are aligned along the field and in the opposite way. So body will have a net magnetization. We move to more important points. In MR, I told there is a very strong magnetic field. What is the usual magnetic strength, field strength? Field strength is when the field is very high, it is expressed in the unit Tesla. If the unit is very small, if the magnetic field is very small, it can be expressed in another unit known as Gauss. Earth is said to have a magnetic field. It is 0.5 Gauss. 10,000 Gauss is 1 Tesla. So you can imagine 10,000 Gauss is 1 Tesla. Earth is got a magnetic field of 0.5. So present day MR machines, it is 1.5 to 3 Tesla or even 6 Tesla. That much strong. And there is, apart from magnetic field, another radiation, that is radio frequency rays are also there within the MR system. frequency wave, this nuclear magnet changes its directions. When we withdraw this radio frequency wave, they come back to its original position. So there is a change in magnetization, and that is measured by the system. Don't go to the detail. But by heart, what is known as Faraday cage. It has come in one question. Faraday cage. Faraday cage is a copper wire mesh used, usually concealed. It will not be seen outside. Within the MR room, it is a copper wire mesh, and its function is to prevent interference by the external radio frequency waves. Faraday cage is used in MR, at least that much minimum, not in CT, not in ultrasound. Faraday cage. MR has got very superior soft tissue contrast, everybody knows that, and magnetic metallic objects, if they are present within the body, it's an absolute contraindication for MR, like aneurysm clips, pacemakers, etc. Ultrasound, piezoelectric property of certain crystals. Certain crystals vibrate when an electrical potential is applied. Reverse is also true. When these crystals are mechanically stimulated by some vibration, again by the same ultrasound or sound, electrical potential is generated. So you might have seen the ultrasound probe applied on the patient. This probe will emit ultrasound intermittently, not continuously. In microseconds it will emit, it will stop for another microseconds, again it will emit. In between it will receive the ultrasound that is reflected from the body. That is the function. And this received ultrasound that are reflected from our body is converted back to electrical energy, and it is calculated by the computer, and we see the image. That is the minimum thing. And again, how we can see the different organs. Different organs or tissues reflect ultrasound waves in different manner. So the electrical energy generated by these reflections are different for different organs. Liver will reflect in one fashion, fat in another type, spleen another type, like that. So we can see different organs in different shades of grey. Crystal used in ultrasound, that we have to write down, which is PZT, sometimes short form, PZT, lead zirconate titanate. Again, important frequency range you have to know. Routine abdominal ultrasound, it is 3.5 to 5 MHz. 7.5 MHz for transvaginal and transrectal scan, so-called endocavitary scan, body cavity, probe is within the body cavity. 10 to 12 MHz for endoscopic ultrasound. Using 20 to 25 MHz, you can see different layers of the skin, epidermis, dermis, like that, is the frequency range. There is one more advanced machine known as, sometimes called as ultrasound biomicroscope, used to study the, what is it called, in glaucoma, that angle, canal of Schramm, isn't it, that area. So it will show all layers of cornea. You know, there are 5 layers of cornea, and you know what is these different layers, isn't it? 10 layers for a retina. So where the frequency range is 40 to 100 MHz. Another ultrasound is Doppler. Doppler will show direction as well as velocity of blood flow. Not only blood, if any fluid is moving with sufficient velocity, it will show some Doppler effect. For example, ureteric peristalsis can be detected within the bladder by urine jet coming in the bladder. So, if there is obstructive uropathy, you can concentrate on one of the ureteric orifice and look for whether urine jet is there or not. Suppose stone is there, obstructing ureter, that side there will not be any urine jet. So that can be detected by Doppler. So CT scan is X-ray attenuation. Another modality is PAT, positron annihilation. Scintigraphy is the term for radionuclide imaging. This thing calls a lead zirconium titanate for USG for ultrasound crystal. Calcium tungstate is a crystal used in the X-ray screen for routine X-ray film radiography. You might have seen that X-ray film is kept within a box. That box will have these calcium tungstate crystals. Next is on scintigraphy. Makes use of radioactive isotopes. Radioactive materials emit various types of radiations: neutrons, alpha rays, beta rays, gamma rays, etc. Most destructive rays are among these are anybody. If gamma is most destructive, then how can it be used for imaging purpose, diagnostic purpose? Alpha rays are most lethal, 20 times more harmful than gamma rays. Nuclear explosion, atom bomb explosion, where lot of alpha rays are emitted. Gamma rays are relatively less harmful, so that it can be used for diagnostic purpose. For radionuclide imaging, we have to pick up these gamma rays, so we have to have gamma camera that is capable of picking up gamma rays. So these are radionuclide imaging, scintigraphy, PET, etc. are together known as functional imaging or metabolic imaging. One question was, for technetium 99M, what does this M stands for? That is one question. Anybody? M stands for metastable. That is one question in modern day. Many points to be noted down. For in technetium, the most common radionuclide material used for diagnostic purpose, because it has got very least or very less side effects, very less radiation risk. Radiation risk is very less because half-life is only 6 hours. So not down regarding half-life of technetium, it is only 6 hours. We have iodine rays and iodine 123 units gamma rays. So beta rays are tissue destructive. So what do we want is destruction of the thyroid tissue, isn't it? Ablation. So here we make use of iodine 131, which half-life is about 8 days. Iodine 123, I think it is 2 days. Just check it out. 2 to 3 days. Iodine 123. So one emits gamma ray, another emits beta rays. Interesting. Technetium previously is prepared from radioactive molybdenum, and somebody gave the name as milking, process of milking. So radioactive molybdenum was known as technetium cow. Radioactive molybdenum is a technetium cow, and the process is known as milking. So this technetium is attached with various compounds. For example, technetium is tagged with methyl diphosphanate, a phosphate. Phosphate will ultimately get deposited within the bone, calcium phosphorus. So technetium methyl diphosphanate is the agent for bone scanning. Okay? Technetium DTPA is used for renal scanning. Technetium sulfur colloid is used for liver scanning. Technetium tagged with RBC is used for occult GI bleeding. Sometimes not only technetium, sometimes indium is tagged with leukocytes to diagnose deep-seated abscess. Indium leukocyte scan. There will be leukocyte colonization around any abscess, isn't it? We will come to that later. So technetium 99, N stands for metastable. What does this 99 stand for? Number of neutrons. What are radioisotopes? Isotopes differs only in atomic mass because of the number of neutrons vary. If the number of protons changes, it is no more the same element, isn't it? So number of neutrons varies. So 99 stands for number of neutrons and N stands for metastable. Contrast agents, MR, gadolinium. CT scan, we have iodinated intravenous contrast agents. Even though not used nowadays, we should know these names. Contrast agent of choice for bronchogram is dianosyl. If asked in question, we have to know this. For myelogram, it is iodoxol. For lymphangiograph, it is lipiodol. Oral cholecystogram, it is hyaluronic acid or its sodium salt or sodium hypodate. Iodine particle ratio, you can take down that regarding the iodinated intravenous contrast agents. For ionic agents, iodine particle ratio is 3:2, and for non-ionic agents, that is the usual ionoxol, or nowadays well, we use only non-ionic agents. It is 3:1. Iodine particle ratio means number of iodine atoms is to per number of particles per molecule. If one molecule ionizes, there are two particles, one positively charged and other, isn't it? So non-ionic per molecule only one particle. Number of iodine atoms are 3, so it is 3:1. For ionic, it is 3:2. Radiation protection, these units, radioactivity units are expressed in becquerel, megabecquerels. There are two units. Curie is a very large one. So drug dose used to be microcurie, this much microcurie of radioactive iodine. Now it is very small unit in becquerel, so 80 MBQ, megabecquerels. Radiation dose is expressed in gray, previously known as rad. Absorbed radiation present unit is sievert, millisievert. One chest X-ray radiation doses is sometimes asked is 0.02 millisievert. Very widely used radiological investigation, chest radiograph, radiation risk dose is 0.02 millisieverts. Radiation into quality factor, that is absorbed radiation. So for the same amount of radiation dose, effects on the body are different. For neutrons, quality factor is 10, that means 10 times more harmful. Alpha rays it is 20. Very important point, should be very thorough about this. Maximum permissible dose for radiation worker. Many times repeated, you can see that many times repeated point is 50 millisievert per year or 20 millisieverts per year for 5 years, 5 consecutive years. Effects of radiation can be broadly divided into two categories. Effects of radiation on the body. One is known as acute effects. They occur within a very short period. Dose dependent effect. That means you calculate the dose, you give this much dose, and this effect is sure to happen. For example, total body lymphopenia is induced by approximately 150 rats. Total body lymphopenia. Total lymphopenia is sometimes induced prior to bone marrow transplantation. So effect can be predicted. That is why it is also known as deterministic. It is sure to happen. And it is known as non-stochastic effect. So acute, dose-dependent, non-stochastic, deterministic. Different names. So they are hematological, lymphopenia, neutropenia, etc. Gastrointestinal, mucositis. What is the turnover time of intestinal mucosa? Anybody? Brush border. 48 hours it is replaced, isn't it? Just check it out, it is 48 hours I think. So these actively multiplying cells are highly sensitive for radiation. Bone marrow is actively multiplying, isn't it? So again susceptible for radiation. Generally neurons, central nervous system, their multiplication is already over, isn't it? So they are relatively resistant to radiation. Next group is delayed effects. They are non-dose dependent. We don't know at what dose it happens. Some individuals develop leukemia even with a small dose. Some individuals will not develop even with a large dose. This is just like a development of cirrhosis and alcohol intake, isn't it? We cannot predict. We can see many people, irrespective of the quantity of the large quantity of alcohol consumed, they will not develop cirrhosis. There are many other factors playing. Similarly, delayed effects, it is not dose dependent. You cannot predict also. Only some will develop leukemia. You irradiate 100 individuals with very high dose. All of them will not develop leukemia. Only some will develop leukemia. And we cannot say who are going to develop this. So it is known as non-deterministic. Non-deterministic, non-dose dependent, delayed, also known as stochastic effects. So note down that point, stochastic and non-stochastic. A funny terminology, but one is acute, other is chronic, one is deterministic, other is non-deterministic. One is dose dependent, other is not dose dependent. And these stochastic effects or delayed effects are development of leukemia, genetic effects, carcinogenesis, etc. So that was about the brief introduction. So this question is on imaging features of hepatocellular carcinoma. So liver has got a dual blood supply, isn't it? What percentage by portal vein and how much by hepatic artery? Anybody? About 20-80 or 80-20, 80 by portal vein and 20 by hepatic artery. Hepatoma is almost 100% by hepatic artery. Most of the bone tumors are mainly supplied, not on the liver, most of the liver tumors are mainly supplied by hepatic artery. So if you know this point, then even you don't know the answer, you can try to derive the answer. Hepatomas are supplied mainly by hepatic artery. So it will show. And one more point, hepatoma is one tumor which will show very high arterial venous shunting. Neovascularization, tumor neovascularization resulting in arterial venous shunting. If you know these 2 points, hepatoma main blood supply is from hepatic artery and there is lot of arterial venous shunting happening. And with this knowledge, if you approach this question, characteristic feature of hepatoma in CT and MR is early arterial enhancement and washout in portal phase. So that is the basic of this question. So there is early arterial enhancement and washout in portal this phase. Having a definitive treatment for cirrhosis with epithelioma, liver transplantation, isn't it? Cirrhosis with epithelioma, definitive treatment is liver transplantation. Chemoembolization is the treatment for inoperable hepatoma. If hepatoma is confined to one lobe, we can go for resection, lobectomy. You can also go for radiofrequency ablation for selected cases. In chemoembolization, what is done is hepatic artery is selectively cannulated and the tumor is perfused with chemotherapeutic agents. So, we go to the sub-question. For chemoembolization, that is transarterial chemoembolization, for visualization, which segment is affected and which segmental vessel is to be embolized, they use some radiopaque material. Radiopaque material used along with TACE, that is the transarterial chemoembolization is lipiodol. Lipiodol is the contrast agent for lymphangiogram. Lipiodol is a oily drug. So one of the complications is fat embolism in the lung. Lipiodol is an oily drug. So fat embolism is one of the complications. Go to next question. Chest X-ray shows perihilar around the hilum, ground glass opacity, interstitial shadows and nematoceles. Diagnosis is Staphylococcus pneumoniae. If the question is commonest cause of nematocele, that is staph pneumonia, definite. So, interstitial shadows are not seen in staph pneumonia. Staph pneumonia commonest lung manifestation is, if that is the question, commonest radiographic manifestation of staphylococcal pneumonia is bronchopneumonic pattern, which may or may not cavitate. Bronchopneumonic pattern. So bronchioles opacity, interstitial shadows and nematoceles are feature of PCP pneumonia, pneumocystis carinii pneumonia. HIV infection and PCP relation, and the CD4 count at which PCP infection comes, between 100 to 250, isn't it? 200 to 250. Other infections, CMV and all, less than 100, 50 to 100, that range, isn't it? Most common lung manifestation of HIV, lung infection of HIV is pyogenic infection. But problem is, it is not specific for HIV. They are more prone for, like any infection, they are more prone for pyogenic infection, pyogenic bronchiolitis. It is said that this is the most common infection, but this is not not specific. Specific infections are PCP, so peritonial valvular opacity, interstitial shadows and nematocele are seen in PCP pneumonia. Nematoceles are seen in staph pneumonia, PCP, Corazon pneumonia, Klebsiella pneumonia. Sometimes traumatic lung injury, pulmonary laceration. Sometimes following lung infarct, thromboembolism and pulmonary infarct. So once again, nematoceles, most common staph, followed by PCP, hydrocarbon pneumonia or Corazon pneumonia, pulmonary laceration, Klebsiella pneumonia, when the choice hydrocarbon pneumonia cavitate, isn't it? PCP pneumonia cavitate, staph pneumonia cavitate, pulmonary hemocirrhosis will not cavitate. Pure pulmonary hemocirrhosis will not cavitate. Most common cause of pulmonary hemocirrhosis is, and we're discussing about sub-questions, most common cause of pulmonary hemocirrhosis is mitral stenosis. Mitral stenosis. Heart failure cells, isn't it? Chronic venous congestion lung, CVC lung, isn't it? In pathology you might have seen that slide. Heart failure cells. Heart failure cells are macrophages filled with hemosiderin. This is common in mitral stenosis. So points to be remembered as pulmonary hemocirrhosis will not cavitate, and you should know the conditions where nematocele is possible. Not that nematoceles are seen in every PCP pneumonia. Nematoceles are seen approximately 20% of PCP pneumonia. These nematoceles, they are acquired thin-walled air-containing cystic lesions. Nematoceles are acquired thin-walled air-containing cystic lesions. Straightforward question. Staging of lymphoma by functional imaging is done by 18 FDG PET, 18 fluorodeoxyglucose PET. Previously used to be gallium scan, gallium 63, gallium scan. Its advantage is response to treatment can be monitored. A lymph node with normal size can be diagnosed. Sometimes lymph node may be of normal size still harboring malignant cells. This can be detected by 18 FDG PET. Sterile lymphoma. One interesting term is sterile lymphoma. You will see this terminology in oncology books. Sterile lymphoma refers to non-malignant, mostly fibrous tissue, residual fibrous tissue when the lymphoma is treated either by radiotherapy or chemotherapy. When a large lymphomatous volume tissue is either irradiated or subjected to chemotherapy, it gradually decreases in size, but some amount of fibrosis also happen and some residual tissue will be there. If you take biopsy, there will not be any malignant cells. But if you imagine CT, ultrasound, MR, etc., we will see some residual tissue. So this is term name given is sterile lymphoma. seen in small vessel occlusive disease. You think about all possible small vessel occlusive or vasculitic disease. Diabetes, steroid intake, Cushing syndrome, SLE, mechanism may be different. Pregnancy, highly thrombotic state, then sickle cell disease, very important, sickle cell disease, pancreatitis, vessel occlusion. You can even get central retinal artery occlusion in pancreatitis, isn't it? I don't know the name. What is the name for that? Some syndrome. Sudden loss of vision in acute pancreatitis due to central retinal artery occlusion. Let's find out what is the name. Okay? So that is a complication of pancreatitis where vessel occlusion occurs. So back to bone infarct and the choices given. Bone infarct is also possible when there is extensive infiltration of the bone marrow. So that is in Wasser's disease. In few more practical points are bone infarct is very common in medullary cavity. Very rarely affects cortex. Marrow is there in medulla. We all know that bone marrow is not in the cortex, it is in the medullary cavity. Bone infarct radiographically appears sclerotic, dense. Again one point here. Okay. Bone infarct radiographically appears dense or sclerotic. Bone infarct is most often medullary in nature. So any extensive marrow infiltrative or marrow vessel occlusive disease like diabetes, SLE, pancreatitis, these conditions bone infarct is seen. So in this case it is Wasser's disease. So this is characterized by marrow expansion. For diagnostic purpose we aspirate the bone marrow, isn't it? Wasser's disease. Bone infarcts. Then sometimes there will be expansive lytic areas affecting the bone. One of the causes for huge splenomegaly, Wasser's, CML, high risk leukemia, then malaria, polycythemia, these are the causes for huge splenomegaly. Kala-Azar, very important in our country. Kala-Azar, malaria, chronic myeloid leukemia, Wasser's, hairy cell lymphoma, isn't it? Causes for what is Casey's disease? Decompression sickness. Which gas is responsible for Casey's disease? Nitrogen. Nitrogen that is dissolved within the blood in very high atmospheric or very high pressure. When that pressure is suddenly released or when the body is brought to the normal pressure, dissolved nitrogen is suddenly liberated within the bloodstream. These microbubbles will coalesce and will result in embolism. So that is effect of Casey's disease. Decompression sickness. Important point is malignant fibrous histiocytoma may arise from a bone infarct. A malignant tumor that may arise from a pre-existing bone infarct is malignant fibrous histiocytoma, MFH. Evaluation of fistula is known as best done by MR. Now it is a costly affair, isn't it? Previously it was fistulogram because MR has advantage that pelvic floor muscles are best shown in MR. What are the pelvic floor muscles? Levator and muscle that is vestigial in human being and that is very prominent in animals for the function of tail, movement of tail. So that function is not there in human beings, probably. So it is pelvic side wall muscles are we have two important group of pelvic side wall muscles. They are muscles that take origin within the pelvis and comes out of the pelvis and gets inserted to and around the hip joint. They are pelvis is not in the true pelvis, it is in the false pelvis, so it is not considered as pelvic side wall muscle. Obturator internus and lamella is outside, isn't it? Lamella is attached to one tendon. A pear-shaped muscle, piriformis. So piriformis and obturator internus are considered as pelvic side wall muscles. Pelvic viscera like bladder, uterus, prostate, etc. are well shown by MR. Next question is on synthesis pubis. In our body we have hyaline cartilage, fibrous cartilage and elastic cartilage, isn't it? Examples of elastic cartilage are pinna, epiglottis and part of eustachian tube, part of external canal, isn't it? Fibrous cartilage mainly arranged along the midline, intervertebral disc, mandibular channel, then pubic symphysis. Pubic symphysis is fibrous cartilage, mainly fibrous cartilage. Pubic symphysis will be widened in conditions where pubic bone will not develop. Congenital conditions where pubic bone will not develop. Or acquired conditions where pubic bone is eroded or deossified. So congenital conditions where pubic bone is poorly developed are cleidocranial dysostosis and ectopia vesica. Erosive condition where pubic bone is eroded, destroyed, acquired is rheumatoid arthritis. Bone demineralizing condition is hyperparathyroidism. So white synthesis pubis is not seen in, so we can remove rheumatoid, hyperparathyroidism and ectopia vesica. So what remains is prune belly syndrome. And the other name for prune belly syndrome? To study these different names, isn't it? Prune belly syndrome, Barrett syndrome, approximately 5 millimeter in the more than 10 mm is abnormal, more than 25 mm is diagnostic of ectopia vesica. Ectopia vesica is characterized by what all things? Atrophy of bladder. How does it look like? What will be the appearance? There is no abdominal wall, not only muscle, skin also. There is no abdominal wall. Full thickness abdominal wall defect below the umbilicus. Varying degree, size may differ, but thickness is full thickness. Skin, subcutaneous tissue, muscle. Along with that, anterior wall of bladder is also deficient. So what we say directly is posterior wall of bladder. There is no bladder in fact. Below the umbilicus, what we say is posterior wall of bladder or the bladder mucosa. So we have to reconstruct the bladder for treatment. Since the bladder mucosa is constantly exposed, subjected to continuous friction, what will happen if any mucosa is exposed and subjected to continuous friction? Metaplasia. Normal bladder mucosa is transitional epithelium. So the malignant disease is transitional cell carcinoma. But in ectopia vesica, since there is squamous metaplasia, we get squamous cell carcinoma of bladder as a complication. There is one parasite which also repeats the bladder, results in squamous metaplasia and ultimately develops squamous cell carcinoma, that is schistosomiasis or bilharziosis. One important one point is very large or probably the largest pulmonary artery is seen in pulmonary schistosomiasis. Schistosomiasis, one of the lung complications is pulmonary hypertension. So huge pulmonary arteries or probably the largest pulmonary artery is seen in schistosomiasis. Umbilicus is absent in ectopia vesica. Nipple will be absent in Poland syndrome. Nipple will be absent in Poland syndrome. Umbilicus is absent in ectopia vesica. Brown-Billy syndrome is a disease in boys characterized by dilated ureters, deficient abdominal muscles, abdominal wall, not only muscles, hypoplastic prostate, undescended testes and chronical urethra. So upper urinary tract dilatation and lower urinary tract outflow obstruction. That happens in Brown-Billy syndrome. TBI, traumatic brain injury. This traumatic brain injury requires MR for demonstration. Diffuse axonal injury. In CT, one will suspect diffuse axonal injury. CT apparently normal or very minimal findings, but score is very down, isn't it? Very low. GC score is very low. Most common traumatic brain injury associated with depression stress fracture skull. We are discussing possible related question. Most common traumatic brain injury related with depressed fracture of skull is hemorrhagic hemorrhagic contusion. So traumatic brain injury that requires MR for diagnosis diffuse axonal injury. It is characterized by multiple foci of subcortical bright signals in T2 as well as diffusion and gradient signals alterations. Number of carpal bones 2 or 0? 0, so that is no doubt. Number of tarsal bones present at birth? Number of tarsal bones present at birth. You leave radiology, go to forensic, infanticide, that you decide age of the child. You look for certain epiphyses, 1, 2, 3, 4 mainly. Remember these important epiphyses. Epiphyses is an ossification symbol that are present at birth are lower end of femur, upper end of tibia, calcaneum, talus. So 2 tarsal bones are there at the time of birth. Plus epiphyses around the knee, lower end of femur and upper end of tibia. The ossified carpal bones at the time of birth is 0. Chronology of ossification of carpal bones. 4th month, capitate and hamate. It is tricutal. 4 to 5 years it is lunate. 6 years scaphoid, trapezium, trapezoid. Pisiform is the last carpal bone to ossify around the age of 11. Pisiform is within one tendon. Which tendon? Flexor carpi ulnaris. Which part of the scaphoid is likely to go for necrosis or avascular necrosis? Proximal. What is the reason for that? Blood supply is from distal to proximal and there is a relative narrow portion, isthmus avascular portion. Ossification sometimes present at birth, lower end of femur, upper end of tibia and calcaneum. Best imaging modality for acute appendicitis. Ultrasound. That is what we usually go for. For many reasons we may not be practicing the ideal. Don't go for MR. Don't go for MR. General rule, acute abdomen, there is no role for MR. except probably MR is an investigation for endometriosis, but endometriosis very rarely presents as acute abdomen, isn't it? A chronic pathology or a chronic one, very rarely acute abdomen. So, contrast CT is the best imaging modality for acute appendicitis. Acute appendicitis is primarily a clinical diagnosis. If the surgeon feels definitely 100% the patient will get operated in a private hospital, isn't it? In our setup, because of the time factor, anesthesia factor, many things, patient may or may not be operated. But when in doubt, surgeon will go for investigation, and the best investigation as per textbook is contrast CT. But because again it is costly and the radiation risk is there for many factors, frequently we go for higher resolution ultrasound, but for practical purpose, for exam purpose, it is contrast CT. Best imaging modality for acute appendicitis is contrast CT. So acute abdominal conditions and investigations of choice. Cholestasis is ultrasound. Appendicitis, diverticulitis, pancreatitis, CT scan. Ulcerative colitis, barium enema. Acute gastritis, best investigation is endoscopy. What is the best investigation to show diverticular disease? Barium enema. Best investigation for diverticular disease is barium enema. Best investigation for complications of diverticular disease is CT scan. Diverticular disease is the, as per certain, is the commonest cause of colovesical fistula. Commonest cause of colovesical fistula is diverticular disease. Commonest site of diverticular disease is which part of the colon is most commonly affected in diverticular disease? Sigmoid colon. Sigmoid is the commonest site of diverticular disease. Sigmoid colon always lies on the bladder. Alright? Sigmoid is an intraperitoneal structure most often lying on the dome of bladder. So when it is complicated by diverticulitis, it can erode the bladder wall and can result in colovesical fistula. IVP or IVU shows small irregular kidney with focal calcium dilatations. Diagnosis is kidney is small, irregular. Small kidney, congenital small kidney, renal artery stenosis, chronic pyelonephritis, everything can result in small kidney, even segmental renal infarcts. Irregular outline, congenital small kidney is usually smooth outline, so we will remove that. Renal artery stenosis again usually smooth outline, so what remains is segmental renal infarct and chronic pyelonephritis. Out of these two, only chronic pyelonephritis shows focal calcium dilatations. So answer is chronic pyelonephritis. Scarred kidney. Related questions. Radionuclide agent best showing renal scar is recently asked question. Renal radionuclide scan agent. given to demonstrate renal scar. DMSA, technetium DMSA, dimercatosuccinic acid. DMSA for renal morphology and renal scar. DTPA for mainly for GFR and other functions. So renal morphology or renal scar is best by DMSA, technetium 99 from DMSA. Related question is, renal artery stenosis is best diagnosed by among the choices given. It is cartography scintigraphy. Cartography scintigraphy. Doppler sensitivity and specificity varies for renal artery stenosis, very wide range, depending on the machine, operator and patients. There are three variables in ultrasound. Many times it is not highlighted. One is patient. One is very lean patient, best for ultrasound. Very obese, not good for ultrasound. In between, okay, we can adjust. Machines are there, isn't it? Very good machine, the average machine, and very poor machine. Similarly, operators also can be broadly divided into three. So you can imagine the number of permutation and combination. You can very good machine, good operator, very good patient for ultrasound. So best outcome. The other way you can imagine, and you can imagine the combinations possible. So renal artery stenosis is best diagnosed by cartography scintigraphy in screening modality. But gold standard is DSA. Gold standard is DSA. Can also go for CT angiography or MR angiography. So cartography, how does it help? It abolishes the efferent arteriolar vasoconstriction, renal artery stenosis, and decreases filtration pressure. Take down that page kidney. Page kidney. Page kidney is renal cortical compression due to any subcapsular fluid collection, either blood, pus or whatever it is, resulting in cortical compression and decreased perfusion and development of hypertension. Can be hematoma or fibrosis. Compromising the cortical perfusion and resulting in hypertension. Page kidney. So gold standard for renal artery stenosis is renal angiography. So technetium MAG3 is for GFR and blood flow. DMSA is for renal morphology, renal scar. DTPA is for GFR and again blood flow. DTPA can also be used for cystography and reflux. Causes of renal artery stenosis, atherosclerosis in older population, fibromuscular dysplasia, you have to keep in mind, a disease of young females, characterized by beaded appearance of the renal artery, intermittent dilatations and narrowings, constrictions. So in angiogram, we will get string appearance in renal angiogram. String of beads appearance in ERCP is diagnostic of chronic pancreatitis. String of beads appearance in plain X-ray is diagnostic of small bowel obstruction, acute small intestinal obstruction. String of beads in renal angiography is fibromuscular dysplasia. So one in ERCP, one in angiogram, other one in plain X-ray. So after every 10 questions, one slide will be there. It is not in question form, simple point form. That will not be definitely there in your printed matter, so you can take down this. Scottish dog, the most popular sign is an erect spondylolisthesis. That almost everybody knows. So, you are not included in that. It is Napoleon hat sign, again in spondylolisthesis. Almost all of these are previous questions. Bird of prey, thumb sign, riblace, heart nodule of salivary gland, spring coil, fishy ureter, penicillin cup, etc. Finished? Let me ask a few related questions. What is spondylolysis? Yes? Spondylolysis is defect in the pars interarticularis. It is said to be a stress fracture, chronic repetitive trauma. Spondylolysis is almost invariably associated with spondylolisthesis. Spondylolysis is defect in the pars interarticularis. Because of the spondylolysis, you get decapitation of the Scottish dog, beheaded Scottish appearance, beheaded Scottish terrier appearance. Heart nodule in salivary gland, only tumor appearing as a heart nodule, only salivary gland tumor. All of the remaining are cord nodules. Wartings or adeno lymphoma. Thumb sign, nothing to do with the thumb or ulnar nerve. It is a radiographic picture. When you take a lateral view of the neck, soft tissue neck lateral view, edematous epiglottis profile will look like this, thumb. So that is what is known as thumb sign. So that is penicillin cup is Psoriasis. Psoriasis, arthritic changes sometimes can precede dermatological changes. Very rarely arthritic changes may precede. Psoriasis, gout, and neuropathic arthritis. These are probably three arthritic varieties which will not show osteoporosis, bone demineralization. Bone density is normal in psoriasis, neuropathic arthritis, and gout. So next we will move to next question on malnutrition. In the development of gut, major part of the gut lies outside the body. It is known as extra embryonic coelom. Body cavity, peritoneal cavity is partly outside. That is extra embryonic coelom. It is mainly the midgut that remains outside the body for a short period. Subsequently, these midgut will recede back to abdominal cavity, that is the intraembryonic coelom. Along with this recession of the bowel lobes back to the abdomen, fixation of the gut, various parts of the gut will also recess. As a result, stomach becomes horizontally oriented. To begin with, it is like cranial-caudally arranged tube. GIT is cranial-caudally arranged tube. Stomach is horizontally oriented. Then part of the duodenum becomes, or major part of the duodenum becomes retroperitoneal on the right side, across the abdomen, and a small portion on the left side. Okay? Then jejunal lobes comes in the left upper quadrant because duodenal jejunal flexure is to the left side of spine. Ligament of Treves goes from the duodenal jejunal flexure towards the and part of the colon, hindgut, ascending colon as well as descending colon becomes retroperitoneal structures. So this starts at what time rotation of the gut starts? 7th week of intrauterine life and is complete by 11th week. When there is malrotation, root of mesentery becomes small. When the mesentery is small, what is the risk? You have similar thing happening in torsion testis. Testis with small mesentery called bell clasper or clapper. What? Okay, bell clapper testis. That makes it susceptible for torsion. Solid organs we call it torsion, hollow viscous we call it volvulus. That is the basic difference, essentially the same. Okay? So, it is a midgut which suffers. So, malrotation of the gut is often complicated by midgut volvulus, midgut volvulus. Artery of midgut is superior mesenteric artery. Artery of foregut is celiac axis. Artery of hindgut is inferior mesenteric. So everybody knows that. And superior mesenteric artery branches are mainly within the mesentery, isn't it? Malrotation of that is best diagnosed by, in malrotation, iliocecal junction becomes abnormal, diagonal jejunal flexure becomes abnormal, ascending colon or ascending colon may be in an abnormal position, plus there can be other associated lesions. What are the other associated lesions of malrotation? Sometimes we will get an abnormal peritoneal band, that is known as Latz band, very common accompaniment of malrotation. Most important point to be looked for diagnosis of malrotation is duodenal jejunal flexure. We look at duodenal jejunal flexure whether it is there in the normal position or not. It is the most important point. This can be best evaluated by, if you know that it is duodenal jejunal flexure, then best investigation to show duodenal flexure is barium meal follow through. So that is the best investigation for diagnosis of malrotation. You can get reversal of superior mesenteric artery and vein. Normally superior mesenteric vein is to right side and artery is to left side in the root of mesentery. So this relation may be reversed. So malrotation that is best diagnosed by barium meal follow through. So what is important is to look for duodenal jejunal flexure, which normally should not overlap the spine. It should be somewhere here, behind the stomach. Normal rotation is 270 degree anti-clockwise. Latz band will result in, Latz band is an abnormal peritoneal band that stretches across the second part of the duodenum. So it will result in duodenal obstruction. One related question is, commonest cause of duodenal obstruction is duodenal atresia, not Latz band. Commonest cause of duodenal obstruction in newborn is duodenal atresia, then comes Latz band, annular pancreas, etc. You can get whirlpool sign in barium and CT in malrotation, midgut volvulus. Whirlpool sign is in malrotation of midgut. Most popular sign of duodenal atresia is double bubble. Double bubble, jejunal atresia. Chromosomal anomaly, duodenal atresia, Down syndrome. Down syndrome, any other part of GIT affected? Hirschsprung is this, Hirschsprung. Down syndrome, any malignancy? Leukemia. Down syndrome, renal manifestation? subluxation, hypoplastic content out. Down syndrome, cardiac defect, endocardial cushion defect. This question is Senger's diverticulum. Medium solid. So everybody knows what is Senger's diverticulum, no need to. What is the defect known as? Killian's dehiscence. That is between transverse and oblique fibers of inferior construct, lycopharynx. Yes, only. Pulsion diverticulum and traction diverticulum. There are two varieties, isn't it? Senger's is pulsion. Anything that results in increased intraluminal pressure is known as pulsion diverticulum. Colonic polyps, there are various types of polyposis and many syndromes are there. Importance of colonic polyps is its risk of malignancy. What is the risk of malignancy in familial polyposis coli? 100%. It is only a matter of time, isn't it? And which one is not a radiological sign of colonic polyps? A difficult one, isn't it? See, a polyp may be peduncle, can have a stalk. So we think that is a stalk sign. An end-on polyp with a very short stalk will be outlined by a round, larger circle and a smaller circle due to the stalk. So that makes target sign. A polyp along the side wall of a bowel will appear like an elevation, makes hat sign. So what remains is accordion sign. Accordion sign is a feature of an acute, inflammatory, antibiotic-induced colitis, pseudomembranous colitis. You know, organism, treatment, antibiotic involved as well as antibiotic use for treatment. These are important points for you, isn't it? Not true for neurological importance anyway. But accordion sign refers to is due to extensive thickening of the colonic wall due to submucosal edema. That is, pseudomembranous colitis is characterized by accordion sign, CT finding. Target sign, hat sign, stalk sign, these are features of colonic polyps. Polyps can be hyperplastic, neoplastic, hamartomatous, inflammatory. Inflammatory, post-inflammatory is ulcerative colitis association. Hamartomatous polyps, Pearce Chagres. So, if we go to related point, commonest site of polyps in Pearce Chagres syndrome is jejunal, small bowel, and it's very commonly complicated by induced susception. The size of the polyp is less than 1 centimeter, there is less than 1% chance of malignancy. When the size is more than 2 centimeter, there is 15 to 20% chance of malignancy. Family polyp will 100% malignant potential. Another interesting thing, not with reality, what is the incidence of congenital heart disease with normal situs? Normal situs means you have abdominal situs, bronchial situs, cardiac situs. Abdominal normal situs means right-sided liver, left-sided spleen and stomach, isn't it? Normal bronchial situs means 3-lobed lung on right side and 2-lobed lung on left side. Cardiac situs, right atrium, right-sided, IVC on right side. It is said that in all normal cardiac situs and abdominal situs, incidence of congenital heart disease is less than 1%, 0.7, something like that. Most common congenital heart disease is bicuspid aortic valve. When there is dextrocardia with situs inversus, incidence of congenital heart disease increases to 5%. When there is only dextrocardia, abdominal situs is normal. Congenital heart disease is 90 to 95%. When heart is normal, abdominal situs is reversed, incidence of congenital heart disease is 100%. It is known as isolated levocardia. Abdominal situs reversed, cardiac situs normal is known as isolated levocardia. Abdominal situs normal, cardiac situs reversed is known as isolated dextrocardia. Now to colonic polyps, Purus, Gardner's, Turcots. Gardner's are polyps with osteomas. Turcots, metallurgical and brain tumors. Purus, hamartomas. Cardiac tumor, dermatological manifestations, malabsorption, etc. Isn't it? Unfortunately, these things are coming in questions, isn't it? Nowadays, questions are becoming more and more difficult. Epidermoid and arachnoid cyst. Intracranial epidermoid and arachnoid cyst can be differentiated by diffusion imaging. Importance is both arachnoid cyst and epidermoid in CT scan more or less show same features. Sometimes you can write only differential diagnosis, either arachnoid cyst or epidermoid. In MR, it can be differentiated by diffusion. Chemical meningitis. When a tumor ruptures, the contents are liberated in subarachnoid space to the CSF. That results in an irritant meningitis, chemical meningitis. That is very peculiar for epidermoid. Rupture epidermoid will result in meningitis, aseptic meningitis, non-bacterial meningitis. retinal cyst. Commonest site of retinal cyst is anterior temporal region. Most of the retinal cysts are incidental findings, asymptomatic. Majority of retinal cysts are asymptomatic, incidental findings. MR imaging sequence that can show white matter tracks is known as diffusion tensor imaging. CT angiogram sign. Popular CT sign. When a CT scan is, routine CT scan is taken, you get an angiographic picture-like appearance in lung. CT angiogram sign. Bronchoalveolar. Because bronchoalveolar, the tumor is, what is a peculiar clinical behavior of tumor characterized by bronchuria, too much of a watery frothy sputum, isn't it? High volume sputum, watery sputum. So density will be less. So the cells become stands out. So CT angiogram sign is classically seen bronchoalveolar carcinoma.
അയ്യോ ഇവർക്കൊന്നുമില്ല അയ്യോ ഓക്കെ
CT angiogram sign is seen in bronchoalveolar carcinoma. Another important point to remember is air bronchogram. Air bronchogram, classical of pneumonia. Air bronchogram shows that lung is diseased but bronchi are patent. Very typical of pneumonia. Majority of the malignant lesions, air bronchogram is absent except bronchoalveolar and lymphoma. Right? systems, vaginas, that is respiratory as well as renal. When respiratory system is affected, most commonly vaginas affects upper respiratory tract. When lower respiratory tract is affected, upper respiratory tract is invariable. Upper respiratory tract involvement is invariable. So, when in doubt, go for CT or X-ray of paranasal sinus. If you take a chest X-ray, you got suspicion of vaginas, go for CT or X-ray radiograph of paranasal sinus, and if the sinuses are affected, it is a very strong point in favor of vaginas. Pulmonary vaginas is characterized by fleeting shadows. Shadows appear and reappear. When they appear in the same point, same area. Nodules, it may be in the form of consolidation or mass lesion like nodules. Some of nodules may cavitate. So radiology will find it not seen in vaginal gangliomatosis is pleural effusion. Pleural effusion is not primarily seen in vaginals. But I already mentioned, sinus opacification is upper respiratory tract is invariably affected. We can also get a positive fading vessel sign. One sign seen in 3-4 conditions. You get a nodular shadow, rounded lesion, and you can see a vessel going to that, fading vessel. This is seen in vaginas, pulmonary ileum, pulmonary arteriovenous malformation, a septic emboli, pyonic abscess. It dilutes at the tip of embolus, a tip of vessels. Feeding vessels are positive. Hematogenous lung metastasis. You will get metastatic mass developing at the tip of an artery. So metastasis, septic emboli, pulmonary ileum and vaginas. These are the 4 causes for positive feeding vessel sign in HRCT lung. Vaginas showing cavitating lesions. Next question. In a trauma setting, chest X-ray of a polytrauma patient shows mediastinal otomy, left pleural effusion, left apical pleural cap and deviation of lower trachea and bronchus to right side. Most likely diagnosis is the lower trachea and bronchi are deviated to right side. Which organ is immediately to left side of trachea, lower trachea? Which structure is to the left side of lower trachea? Aortic arch. Aortic arch. You go by anatomy and the possible pathology. Okay, in a trauma setting, if the lower trachea is pushed, so there is something happening to the left side of lower trachea. Okay, that pathology is associated with left pleural effusion, apical pleural cap. So, answer is rupture occurred at the junction of mobile and fixed portion. Many traumatic injuries are like that. Most common site of fracture spine is related one. Most common site of fracture spine is lower thoracolumbar junction. That is the junction of relatively mobile and fixed portion. Thoracic vertebra is relatively fixed because of the effect of ribs and sternum. Lumbar vertebra is mobile, so junction of mobile and fixed portion. So lower dorsal upper lumbar, thoracolumbar junction. Similarly, in traumatic aortic injury, arch of aorta is said to be relatively mobile. At the same time, descending aorta is relatively fixed. So junction of arch and descending aorta, it is known as aortic isthmus. That is the site of rupture. Commonest cause of esophageal rupture is iatrogenic. Commonest cause of esophageal rupture is iatrogenic. Esophageal rupture is characterized by mediastinal widening. Clinically, what will you look for? Palpate the root of neck for subcutaneous emphysema. So mediastinal emphysema ascending up to the root of neck, surgical emphysema. Because of mediastinality, you can get air fluid level. Fallen lung sign is seen in, if question is on fallen lung sign, bronchial rupture. Imagine if the right main bronchus or left main bronchus is completely broken or severed or detached from the trachea bronchi, the remaining trachea. What will happen? Lung will lose its support. It will hang by the vascular pedicle, pulmonary artery and pulmonary veins, but they are not of sufficient strength to support the lung, so lung will fall to the bottom. When the bronchus ruptures completely, it will invariably result in a open pneumothorax. So there will be an open pneumothorax with lung hanging down from the hilum. A collapsed lung hanging down from the hilum, lying dependent in the posterior part. That is, fallen lung sign is seen in bronchial rupture. Esophageal rupture, commonest causes, iatrogenic. Most common site of esophageal rupture, cricopharynx. Narrowest part of EIT is cricopharynx, isn't it? Most of the foreign bodies get impacted at cricopharynx, coins, etc. But children swallow cricopharynx. Other types of esophageal ruptures are Borhans syndrome. Borhans is full thickness esophageal tear. Classical is a patient vomiting in full stomach. I don't know whether it was 5 or 6 years ago. A classical case happened in our casualty. A young boy was brought to casualty. In the middle of an eating competition, after eating from 24-25 idlis, he vomited. That much volume of is suddenly delivered to esophagus. Esophageal distance not able to accommodate gives way. This has happened. So that is a typical Borhans syndrome. Malarious is partial tear, not full thickness tear, mucosal tear. So rupture esophagus is best diagnosed by esophagogram, a contrast study. The typical malarial is lower end of esophagus rupturing and contains right to left pleural cavity. Open ring sign, the sign described in MR. Open ring sign in MR brain is, you might have heard about ring enhancement, isn't it? Ring enhancement is a complete peripheral enhancement. It need not be smooth outline, it can be of a regular outline, then also we call it as ring enhancement. Ring enhancing lesions are tuberculoma, toxoplasma, abscess, metastasis, then cystic tumors like dermoid, okay? And then sometimes a resolving hematoma, a resolving case of infarct. So abscess, tuberculoma, metastasis, these means the major ring enhancing lesion. But when the ring is incomplete, the short segment is not complete. It is known as an open ring sign. Open ring sign is suggestive of olfactive demyelination. Towards the cortex, ring will be incomplete or deficient. The points to be noted are white matter disease, investigation of choice is MR. CT scan images are most often normal in demyelinated diseases. Dawson's finger is the name for demyelinating plaques in multiple sclerosis. Ecclesia cardia. Best radiological modality is for our diagnosis of external cardia, variance follow. Failure of relaxation of cardiac sphincter. So as a result, food and fluid accumulates in the esophagus, slowly accumulates. Initially, esophagus will try to overcome the obstruction by increasing the peristalsis. This stage is known as vigorous achalasia. Very early phase of achalasia, esophageal muscle will try to overcome the obstruction by increasing the peristalsis, and this stage is known as vigorous achalasia. Esophageal muscle subsequently goes for fatigue or peristalsis becomes ineffective. Esophagus slowly starts dilating. There is more and more accumulation of food and fluid in lower esophagus. Since esophagus is always filled with fluid, what will happen? One effect is risk of aspiration. Alright. Another important radiological manifestation is esophagus resulting in widening of mediastinum. Okay. Any other? Any other drip set? You see a air trap, isn't it? What is the function of that? One is to adjust the drop, isn't it? Second is micro bubbles are trapped within that small reservoir. Similarly, air that we swallow is unable to enter the stomach because of the presence of fluid. If there is no fluid in that trap, in the IV set, microbubbles will enter the immune system. So since there is always there is some amount of fluid, swallowing air does not go to stomach. So radiographically it will result in absent stomach bubble. Most of the, mainly the stomach air is due to swallowed air. Colonic air is due to production of gas by the bacteria. This is an important step. Upper GIT, mainly it is swallowed air. So there will be absent stomach bubble, consolidation, rat tail appearance. Rat tail is also described for carcinoma of lower end of esophagus. So radiological sign that is not seen is left paramediastinal shadow. A dilated esophagus always goes to right side. Why? When there is a stronger person in the left side, descending aorta, posterior mediastinum, descending aorta is already there on left side. So dilated esophagus makes the mediastinal shadow more prominent on the right side, or it always dilate towards the right side. So absent stomach bubble, a mediastinal widening starting from root of neck going up to the diaphragm. Sometimes we will get air fluid level within the mediastinum. Achalasia mimics are achalasia-like conditions. Scleroderma, scleroderma. Then Chandler's disease, isn't it? Chandler's disease. Hairspring-like picture, achalasia-like picture. You are seeing Chandler's disease because this parasite results in destruction of ganglion cells. So there is mediastinal widening, absent stomach air, consolidation. Achalasia is said to be pre-malignant condition. There are some 6 or 7 pre-malignant esophageal conditions, isn't it? Severe esophagus, acid stricture, achalasia, Barrett's esophagus. What is it? Tylosis. I don't remember the full list. Then malignancy develops in achalasia. Where does it develop? The proximal esophagus or distal narrow portion? It doesn't develop in the narrow portion, it is in the upper portion, mid portion. Next question is also 1-year-old child presents with white pupillary reflex. Next investigation of choice is MRI. Child with white pupillary reflex. which condition will you like to exclude first? Retinoblastoma. What is the most characteristic feature of retinoblastoma? Calcification. Calcium DNA complex, very high incidence, 95 to 98%. It is associated with the calcium DNA complex and calcification. Other conditions which result in white papillary reflex will not show calcification. So it has got presence of calcification virtually excludes other conditions also. Okay? So calcification anywhere in the body is best shown by CT scan. So next investigation of choice is for diagnostic purposes CT scan. Then why should you go for MR? Intracranial spread along the optic pathways, along the optic nerve, is assessed by MR. So calcium DNA complex and the presence of calcification within the tumor, 95%. And not only that, if calcification is present, it excludes other conditions resulting in white papillary reflex. It can be bilateral, also trilateral. What is trilateral? Pineal plus bilateral, isn't it? Both eyes. It can be familial, chromosome number 13, isn't it? It is a bilateral retinoblastoma. And the end is Crohn's disease. What is the spelling? It is not. This is wrong. CROHN. CROHN. Crohn's disease. What is Billroth 1 surgery? Distal gastrectomy with the gastroduodenal anastomosis, isn't it? This appearance is seen in pseudo-Billroth 1 appearance. Crohn's disease of stomach. Rugger-Basie spine is seen in renal osteodystrophy, but also seen in osteopetrosis. Rugger-Basie's original description is for renal osteodystrophy. Sometimes for osteopetrosis. Triangular cord sign is for biliary atresia and ultrasound finding. Angle sign is anterior bowing of posterior wall of maxillary sinus. Anterior displacement of or anterior bowing of posterior wall of maxillary sinus. That is classical of nasopharyngeal trauma. Sandstone appearance is in alveolar microlithiasis. What is the chest X-ray finding of alveolar microlithiasis? Chest X-ray finding of alveolar microlithiasis is high density miliary shadings are classically alveolar microlithiasis. This is a very rare condition, but radiology is so characteristic. The bracket sign is for lipoma of corpus callosum. Ewing's sarcoma, most popular radiographic sign is onion peel appearance. So the question is false statement. So first we will remove that, isn't it? Alright. The present question is commonest bone tumor resulting in bone-to-bone mets. It is Ewing's. Second only osteosarcoma. First is Ewing's. Commonest bone tumor bone-to-bone mets is Ewing's, followed by osteosarcoma. So we will remove that also. Then we are left with choice A and C. One is punched out, other is saucerization. We don't know what is saucerization, but definitely we know what is punched out. Means certain terminology is used, it always denotes to some pathology. So punched out always refers to multiple myeloma. Saucerization is due to large soft tissue tumor of soft tissue component of the Ewing's resulting in cortical erosion. This one is saucerization. Term punched out is for multiple myeloma. So false statement regarding Ewing's is punched out destruction. Radiology Ewing's destruction Ewing's is permeative. You have large soft tissue component. You can have bone-to-bone mets, onion peel appearance, saucerization. Fibula is less commonly affected by osteosarcoma, but not frequently affected by Ewing's. Fibula is commonly affected by aneurysmal bone cyst. Adamantinoma of the bone is almost always seen in tibia. Adamantinoma of bone is different, adamantinoma of mandible is different. Both are pathological. So the adamantinoma of bone is almost always in tibia, anterior cortex of tibia. Hansfield, who Hansfield? Scientist who invented CT scan. Hansfield unit of acute extradural abilities. Go to next slide. Hansfield unit originally description ranges from -1000 to +1000. Extreme left we have air. Extreme right side very dense bone calcification etc. The mid portion simply is the density of water. Water means practically flowing within the body like urinary bladder, CSF, gastric juice, so non-proteinaceous fluid. When the protein content of the fluid increases beyond certain level, density goes up. A tissue with minus density is fat. density is fat. Most of the soft tissues in our body are in the range of 30 to 40. Liver has got a higher density because of its normal content. Liver is rich in storage for glycogen. So importance is in glycogen storage disease, liver density is further increased. Example is glycogen storage disease that affects liver is von Gilkey disease. Glycogen storage disease that affects heart is type 1, type 2, isn't it? Complication in glycogen storage disease that affects liver is hypoglycemia, because that glycogen is cannot be utilized, isn't it? Glycogen provides the source for glucose in the fasting state, isn't it? Immediate source is for glycogen, isn't it? Immediate source for glucose is liver glycogen. Okay. Glycogen storage disease complication is the clinical manifestation. Any other complication? What are the pre-malignant conditions of hepatoma? You have hepatitis B, cirrhosis, hepatitis C, glycogen storage disease, hepatic adenoma, hepatoma, hemochromatosis. So hepatic adenoma and hepatocellular carcinoma are complications of glycogen storage disease. So liver density is normally around 50 to 70. Density of thyroid gland is also at a higher level due to reason is different. Again due to normal content. Normal iodine content. Thyroid is rich in iodine. Iodine is a radiopaque material. Iodine is the drug that we give intravenously to make the blood radiopaque or to make the urine radiopaque for IVP, for CT scan, iodine containing drugs. One iodine containing drug, if it is taken for sufficient duration, makes the tissue's density higher. That is, one drug that is an anti-arrhythmic drug that contains iodine, amiodarone. On CT scan it is characterized by very high density of liver because of iodine content again. And because of the same iodine content and the interference with iodine metabolism, complications are hyper as well as hypothyroidism. Alright. So back to functional unit. Most of the soft tissue it is 30 to 40 except liver and thyroid gland which are hyperdense. Bone is of course, bone has got a very high density. Reason is again normal calcium content, mineralization. Flowing blood density is 40, around 40. When blood forms a clot, density is increased and its range is 50 to 90. So here the answer is plus 80. Downstream genital acute extradural bleed is plus 80. Few more points regarding subdural bleed. Extradural is biconvex. Subdural is concave or convex. Extradural can cross the dural fold. Subdural is limited by the dural fold. Dural fold are falx cerebelli and temporal cerebelli. Extradural is usually arterial in nature. Subdural is usually venous in nature. Extradural is associated with lucid interval. Subdural is almost always, acute subdural is almost always associated with underlying brain damage, brain contusion or hemorrhage. Next we will go to cella. Best radiographic view for cella is transvenous is a surgical approach. Lateral view. Lateral view is the best radiographic view for cella. Dimensions of cella are upper limit anterior posterior is 16 mm, height is 10 to 12 mm, width is again 12 to 15 mm. Another interesting thing is posterior lobe of pituitary is very bright in MR, even bright in MR. Absence of this bright signal of posterior pituitary in MR is diagnostic of is seen in diabetes insipidus. Now let us come back to J-shaped cella. J-shaped cella or also known as omega cella. Omega cella. This is due to very deep sulcus chiasmaticus. Now what is sulcus chiasmaticus? Name is sulcus chiasmaticus, the groove where the optic as is lying, is resting. When this groove is deepened, you get omega shaped or J shaped cella. So optic aneurysm groove can be deepened in, now you can imagine, chiasmatic glioma. Okay. To chronic hydrocephalus, because optic aneurysm and optic iris will have a dural sheath, dura and arachnoid and CSF around. So chronic hydrocephalus, yes. Then MPS 1 or Höhler is characterized by thickening of the dura. This can also result in very deepening of sulcus chiasmaticus. So what is remaining is cretinism. In fact, in congenital hyperthyroidism, cella is very small. It is known as cherry cella. Cherry cella in cretinism and omega cella. The name omega cella was originally described for Höhler's MPS 1. So J-shaped is seen in Höhler's chronic hydrocephalus chiasmatic glioma. What is meant by pituitary microadenoma and pituitary macroadenoma. Depending on the size, more than 10 we call it macroadenoma, in less than 10 it is microadenoma. Commonest pituitary macroadenoma is prolactinoma. A pituitary adenoma almost always in less than 10 mm size is always a microadenoma. Cushing's disease. What is Cushing's disease? And the Cushing syndrome is due to pituitary or basophilic adenoma. It is known as Cushing's disease. Radiological findings of pituitary macroadenoma are ballooning or expansion of cella, double flooring of cella, undercutting of anterior clinoid, etc. The best radiographic projection for cella is laterally. Investigation of choice for cellular disease is cellular paracellular area. Best investigation is MR. Next is nephrogram. Name nephrogram refers to increase in the opacity or density of the kidney after giving intravenous contrast agent. For IVP, we give intravenous contrast agent, kidney opacification increases and renal outline becomes very prominent. This is known as nephrogram. We get corresponding increase in density in CT scan. Depending on the appearance of nephrogram, we can diagnose the renal condition. Sometimes, not always. Straight nephrogram or streak-like nephrogram is suggestive of ARPKD, autosomal round recessive polycystic kidney disease, ARPKD. Dense nephrogram is in acute obstruction, complete ureteric obstruction. If you go for IVP, will be very dense nephrogram but no excretion, no urine formation, but nephrogram will remain dense. Delayed nephrogram. Perfusion is compromised, nephrogram is delayed because the contrast has to come through the blood, isn't it? Nephrogram is showing multiple rounded defects due to the presence of multiple cysts. This is seen in ADPKD, autosomal dominant polycystic kidney disease. Cyst is nephrogram. Nephrogram is very thin and peripheral because renal parenchyma is grossly thinned out due to hydronephrosis. This is characteristic of PNJ obstruction. Nephrogram is very much delayed for hours. This is known as shock nephrogram. Usually occurs due to contrast reactions. After giving contrast, patient go for circulatory failure in shock. So immediate nephrogram will not happen. But once a patient recovers, slowly nephrogram reappears. So dense nephrogram, acute obstruction, delayed renal artery nephrosis, nephrographic defect, that is known as multiple defects, known as cis nephrogram means autosomal dominant polycystic kidney disease, crescent nephrogram, not in crescentic nephritis but in biliary obstruction, striate nephrogram, ARPKD, shock nephrogram, delayed, very much delayed nephrogram after recovery from shock. ARPKD, which other system is affected? Liver, in the form of ARPKD, which other organ is affected? Anybody? ADPKD is characterized by cysts elsewhere, cyst in liver, spleen, pancreas, and berry aneurysm in circular release. ARPKD is characterized by development of congenital hepatic fibrosis and portal hypertension. Liver, but not in cystic disease, not a cystic disease, but hepatic fibrosis. Straightening of ileocecal angle. Ileocecal angle is usually 90 degree. Ilium joins cecum and ascending column at 90 degree. This is tuberculosis. So other radiological findings of ileocecal TB. Fleischner sign. Fleischner sign is seen in the chest X-ray of pulmonary thromboembolism. It is different. This Fleischner sign is different. Pulled up cecum, straightened ileocecal angle, stellate sign. Spring sign is also seen in Crohn's disease. Crohn's disease. Chronic cecum, thickened momentum, especially fatty thickening of momentum is also seen in fatty thickening of mesentery is characteristic feature of Robbins pathology. Creeping fat. Crohn's disease, creeping fat, fatty thickening of mesentery is somewhat characteristic of Crohn's disease. Here it will be fibrotic thickening. It is straightening of ileocecal angle. Ileum appears as if suspended from the cecum and ascending column. Most popular sign is water lily sign. Your question is straightforward. Water lily sign is seen in illiver pulmonary hydatid. Most common site of hydatid disease is brain. That is the least common. Liver. Most commonly liver, right lobe, because portal circulation is the first filter. Once it bypasses portal circulation, then it has to go through second filter. Second filter is pulmonary circulation, lung. So in liver, radiographically, X-ray wise, characteristic picture is ring calcification. or eggshell calcification or ring calcification. In hydatid cyst, human being is definitive host or intermediate host. Accidental intermediate host, isn't it? Am I right or wrong? Accidental intermediate host. Definitive host is not. Alright. Hydatid cyst has got 3 layers: endocyst, ectocyst and pericyst. Endocyst is the definitive parasitic epithelium, or not epithelium, parasite, so-called germinal layer. Ectocyst is again part of the parasite or produced by the parasite, the thick, protective, highly proteinaceous covering material, ectocyst. So parasite wants to protect its germinal layer, so it produces ectocyst, thick barrier. So the host has to build something, isn't it? So it results in fibrosis, that is known as pericyst. So pericyst is part of the host. So calcification of the hydatid first occurs in pericyst. Only when the hydatid dies or after treatment, then the ectocyst and endocyst calcifies. The only pericyst calcifies initially. After death of the parasite, the remaining portions calcify. A lung hydatid. Lung is a very loose tissue. There is very poor pericyst formation. And because of that, lung hydatid seldom calcifies. That is the most important point. A calcified ring lesion is almost never seen in pulmonary hydatid. A calcified ring lesion is very common in liver hydatid. Pulmonary hydatid, if it is intact, it will appear like a rounded or oval large lesion, large rounded or oval nodule with very smooth outline. Supposing the ectocyst ruptures, what will happen? Some amount of air will track between the ectocyst and endocyst. So you get a air crescent sign. Alright. Now next is the endocyst also ruptures. So some amount of fluid is expectorated and the germinal epithelium collapses and it floats in the remaining fluid. Then it makes watery sign. Alright. Now, the remaining fluid is also expectorated. Then you will get a double wall lesion, an intact ectocyst and a crumbled endocyst, a double wall lesion. So we will be progressing different radiographic findings in pulmonary hydatid ruptures. Liver hydatid is said to have very high incidence of biliary communication, 25%. So importance is regarding its medical therapy. Previously, formalin was used for injecting into the parasite to destroy the germinal layer. But because of the risk of biliary spillage or the high incidence of biliary communication, once this formalin escape into the biliary tree, it will result in biliary stricture. So now what we use is hypertonic saline, isn't it? Hypertonic saline. I don't know whether any other drugs are there. For direct injection it is done. You can go for albendazole, isn't it? Like that. That is a pulmonary hydrated ectasis is here. Water is completely expectorated or drained out and the collapsed germinal layer is there in the bottom. Air crescent sign is also seen in. Air crescent sign is most commonly seen in our country, aspergilloma. Aspergilloma, hydrated cavitating mass, blood clotting cavity, necrotizing pneumonia or pulmonary gangrene. These are the causes for air crescent sign. This we have already discussed air monograms. Next question is on rib notching. Rib notching, corporation, isn't it? And rib notching is not seen in what is tachycardia? Aorta arteritis. In tachycardia, rib notching is seen affecting lower ribs. In phallus tetralogy, what happens? Lung perfusion is very much decreased, isn't it? Pulmonary blood flow is very much decreased in phallus. Lung is one organ that has dual blood supply, bronchial as well as pulmonary vessels. So when the pulmonary flow is severely compromised, bronchial arteries will enlarge and try to compensate, never completely compensated. Bronchial arteries are branches from intercostal arteries. So any hypertrophy of intercostal arteries will result in rib notching. Rib notching in coarctation is due to dilated tortuous intercostal arteries. You have anterior intercostal vessels and posterior intercostal vessels, isn't it? Anterior from internal mammary, again from first part of subclavian. Posterior from descending thoracic aorta. So one is pre-stenotic segment of aorta, other is post-stenotic segment of aorta. So blood flows from pre-stenotic anterior intercostal artery to post-stenotic posterior intercostal vessels feeding back to the aorta intercostal blood flow is reversed. That is why we are getting radiofemoral delay. The pulse waves takes time to travel through this alternate pathway. So that is the reason for radiofemoral delay in coarctation. So reduction is not seen in pseudocoarctation. The answer. Pseudocoarctation is a radiographic picture of coarctation. Some kinking is there, no pressure gradient, no pressure difference. If there is no pressure gradient, no collaterals. No collaterals, no reduction. Chromosome anomaly? Turner syndrome. What is pre-ductal coarctation? Coarctation proximal to ligamentum arteriosum or proximal to left subclavian. Two more radiographic signs are there in coarctation. 3 sign and reverse 3 sign. When any vessel is narrowed, significantly narrowed, there is a high pressure zone proximal to that narrowing. That area slowly dilates. Just distal to that narrow zone, there is a zone of turbulence because of the jet. Any turbulence will lead to post-stenotic dilatation. So, pre-stenotic dilatation, narrow segment and post-stenotic dilatation makes it 3 sign. This 3 sign on a bearing from the esophagus will appear like reverse 3. An impression on the esophagus bearing finding is reverse 3 sign. So 3 sign and reverse 3. Remember, reverse 3 sign is seen in one malignant condition, that is periambulary neoplasm. Periambulary neoplasm. That is in duodenum, isn't it? Bearing. So coarctation rib notching is from 2 to 8 ribs. Lower rib notching is seen in TACAS. Follows trichlorometry, it is due to major aortopulmonary collaterals. Unilateral rib notching is seen in pre-ductal coarctation, subclavian block, Blalock passive operation sign, etc. Blalock passive operation, etc. 3 sign and reverse 3 sign seen in plain X-ray and barium solver of coarctation. This is rib notching of coarctation. Endoscopic ultrasound, that is the best investigation for local staging of CA, esophagus, CA colon, etc. Tumor staging, T. Frequency for endoscopic ultrasound is 10 to 12 megahertz. Endoscopic ultrasound is 10 to 12 megahertz. It can also be used for CA stomach, pancreatic mass, rectal mass, etc. Rupture urethra. Best investigation for rupture urethra is retrograde study, retrograde ureterogram. Retrograde ureterogram. Rupture urethra is very common in males following fracture pelvis, isn't it? Fracture pelvis. Rupture urethra, next investigation is retrograde urethrogram. Rupture bladder, investigation is cystogram. All traumatic conditions. Liver trauma, CT scan. Renal trauma is CT scan. And related, very rare but interesting name, runner's bladder. Runner's bladder is bladder rupture seen in long distance runner, usually an interstitial rupture. Not full thickness rupture, interstitial rupture of bladder, runner's bladder. What is runner's fracture? Stress fracture of tibia again seen in long distance runners. Stress fracture of tibia is the runner's fracture. Again related to what is March fracture? Alright, what everybody knows, March fracture. Fracture through the neck of second or third metatarsal. Rupture urethra. This study shows Carmen's meniscus sign. That is malignant gastric ulcer, C stomach. Carmen's meniscus sign is C stomach. So we take one by one. Leiomyomai, barium finding is a target sign. Congenital hypertrophic pylori stenosis, barium findings are weak sign, nipple sign, etc. Plain X-ray finding is caterpillar sign. CHPS. There is a metabolic abnormality that occurs in. Okay, you know, all of you know that. Best diagnostic modality for congenital hypertrophic pyloric stenosis is USG, high resolution ultrasound. High resolution ultrasound is the best modality, diagnostic modality. Most of them will diagnose it clinically. The best imaging modality, no risk of radiation, is a high resolution ultrasound. Hampton's hump is seen in benign gastric ulcer. Hampton's hump, ulcer mount, ulcer collar. These three are suggestive of benign gastric ulcer. Carmen's meniscus sign is suggestive of malignant gastric ulcer. Hampton's hump, ulcer mount and ulcer collar. You take down this. Salt and pepper, very popular sign, MR finding, Brown's tumor. Octreotide scintigraphy is for carcinoma tumor. Steeple sign, laryngotracheobronchitis group. child presenting with severe stridor following a mild upper respiratory infection, that is croup. Floating teeth is seen histiocytosis. Langerhans histiocytosis. Panda sign, red panda sign, Wilson's disease, MR appearance. Golden basket sign, pleural calcification. Sausage digitis, psoriasis. Sausage pancreatitis, autoimmune pancreatitis. Autoimmune pancreatitis. Lymphoma, especially Hodgkin's lymphoma. Sausage disease for psoriasis. Bright and black dots. Salt and pepper is for glomus tumor. Face of panda sign. Is for Wilson's disease. One of the following material is not used as X-ray filtration material. I think it needs explanation, isn't it? X-ray filtration materials are used to selectively filter out, to selectively remove low energy X-rays. Because very low energy X-rays are not of diagnostic value, but they simply increase the risk of radiation. Lower the energy of X-ray, more will it absorb. It is the absorbed radiation that is harmful to body. The radiation that passes through and through, completely traversing the body is not harmful. Supposing 100 radiation falls here and the whole 100 comes out of the body, we are safe for practical purpose. But it rarely happens. But supposing very low energy, 100 beams falls here, most of it, 80-90% get absorbed, only 10 goes out. So there is very high risk of radiation. So this low energy radiation has to be removed. So X-ray filters are used in X-ray tubes to remove low energy beams and to improve the radiographic quality and to decrease the radiation dose. So we incorporate certain materials that will selectively remove low energy beams. These materials are metals with very low density. So most commonly they are low densities, aluminum, copper, molybdenum, etc. What is the role of lead? It will prevent all beams, low energy as well as high energy. So lead is used as a protective barrier, not for filtration purpose. Filtration means selective removal of low energy beams. So lead is used as a protective barrier. To questions. Lead equivalent used in barriers or your lead apron. Lead equivalent is 0.25 mm. 0.25. You have big screen or X-ray room door. These to be lined with a lead of 2 mm thickness. 2 mm lead equivalent. That will cut off all X-rays. So filters are used to selectively remove low energy X-rays. This is known as soft X-rays. Molybdenum is used as a filter in mammographic X-ray tube. Special X-ray tube is used in mammography. Next is intercondylar notch widening. Answer is hemophilia. Intercondylar notch of femur gives attachment to cruciate ligaments, isn't it? So they are subjected to maximum stress during sports activities, during playing. So hemorrhage occurs at the attachment of these ligaments, and it leads to bone erosion and widening of intercondylar notch. But that is also seen in intercondylar notch widening is also seen in tuberculosis and juvenile rheumatoid arthritis. Tuberculosis, juvenile rheumatoid arthritis and hemophilia, 3 conditions resulting in widening of intercondylar notch. Let's come back to question. Chondrocalcinosis characteristic feature is in knee is calcification of menisci, meniscus calcification. The discoid meniscus plain X-ray finding is discoid meniscus plain X-ray finding is a widened lateral compartment of knee because of thick or disc-like lateral meniscus. Discoid meniscus 95% affects lateral meniscus. Common in females. Leads to early osteoarthritis. Best diagnostic modality for discoid meniscus is MR. Cartilage imaging is best by MR. Commonest site of hematoma and hemophilia is child presenting with acute abdomen. We examine the patient, he or she looks pale, hematocrit is falling, concealed hemorrhage, retroperitoneal or psoas hematoma. This is followed by hemarthrosis of the knee. A pseudo-tumor-like appearance is seen in hemophilia. Pseudo-tumor-like appearance. It look like a malignant lesion, a osteosarcoma. Tibial intercondylar eminence and anatomy, anterior to posterior attachments, isn't it? vitamin echo is used for myocardial viability. You stress the myocardium by giving vitamin. You increase the oxygen demand of myocardium by giving vitamin. And only during increased oxygen demand, ischemia manifest. So, vitamin echo is one of the myocardial viability imaging. Stress thallium, same thing. 18 FBG PET also same thing. So it is pyrophosphate scan. Pyrophosphate, technetium pyrophosphate will show area that is gone forever, completely infarct area, not viable myocardium. It will show myocardial infarction, completely infarcted area. Every infarct will be surrounded by an ischemic but viable myocardium. Our idea of treatment is to recover this area, either by medical or by surgical means. So, myocardial viability imaging or vitamin echo, stress thallium, 18 FDG PET. What is the peculiarity of myocardium? There are many peculiarities of myocardium regarding physiology, before radiology. What is the oxygen tension of coronary venous blood, coronary sinus? Physiology, but it is important for MCQs, isn't it? I don't know the correct value, but oxygen extraction by myocardium is very high, unlike other tissues. So that coronary venous blood oxygen tension is very low. What I remember is, it is around 20, I think, isn't it? Let's check it out. Anyway. And myocardium energy requirement, what is physiology peculiarity? And free fatty acid can be utilized, isn't it? Brain cannot utilize these things. Brain is dependent on glucose, isn't it? Within the myocardium, blood flow is minimum at subendocardial area, isn't it? Because this area vessels are surrounded by muscles, isn't it? So this area is least perfused. So infarct always occurs at subendocardium. Remember, the radiological importance of that is subendocardial infarct is best shown by MR, not by other modalities. Subendocardial infarct is shown by DEMR, delayed enhancing MRI. What is P50? P50. Not radiology, isn't it? I thought we leave it some very boring, isn't it, radiology? What is P50? Very important for you.
I don't
I don't know whether the name is it. It is the oxygen tension at which hemoglobin is 50% saturated, isn't it? Got it? P50. Am I right? This one question is invariable at this point. Oxygen dissociation curve, shift right, shift left, P50, arterial oxygen tension, percentage, etc. Isn't it? question is invariable in this area. Shift to right, factory selecting, shift to right, shift to left, hemoglobin is these nonsense things. Whatever it is, okay? So P50 is oxygen tension at which hemoglobin is 50% saturated. That is 27. Usually normal oxygen tension is 100. In 100, oxygen saturation is normal oxygen, artificial oxygen saturation is pulse oximeter കിട്ടിയതല്ലോ ഒരാൾക്ക് എത്ര വരും 97. Why it is not going to 100? There are some veins directly draining to left side, Tibial veins, isn't it? Left side of heart. So some venous admixture is there. Of course, we leave out, isn't it? Myocardial viability, diabetes, stress highlight. So 18 technetium pyrophosphate shows it is infarct avid scan. Remember this, thallium scan, stress thallium has the highest radiation dose. 18 millisievert with 80 mbq. One chest X-ray is 0.02 millisieverts. So how many chest X-rays will be this? 900 chest X-rays. Okay? Now you go to radiology rickets. Yes? Yeah, alright. So it is reappearance of white line, not by serum calcium, not by phosphorus, not by alkaline phosphatase. You treat the patient, repeat an X-ray, radiograph after 1 week. Within 1 week's response will be there. Reappearance of that indicate prompt response. If it is not responding, we will think about non-nutritional causes of rickets. Vitamin D resistant rickets, vitamin D dependent rickets, remaining things are there, isn't it? Hypophosphatemia, etc. First sign of rickets is, I have changed the question. First sign of radiographic sign of rickets is if first sign of healing is reappearance, first sign of disappearance of white line. Absence of white line is the first sign of rickets. Then comes widening, cupping, flowing, etc. So, normally mineralized growth plate constitute normal metaphyseal white line. Metaphyseal white line is lost in rickets. Metaphyseal white line becomes prominent in scurvy. Metaphyseal white line is lost in rickets. Metaphyseal white line is prominent in scurvy. It is known as white line of Frankel. White line of Frankel. Radiology of rickets in the order: loss of metaphyseal line, white line, widening, cupping, fractures, secondary hyperparathyroidism, etc. So, we thorough with calcium phosphorus, these 25 hydroxylation, 125 hydroxylation, liver kidney. For calcium phosphorus product, many things are there, isn't it? For proper mineralization. Structure of bone framework is by collagen, isn't it? Bone is combined with a reinforced concrete. it, isn't it? The steel bars are collagen. The steel bar disease is affecting bone is collagen framework is affected. A bone disease where the collagen framework is primarily affected. Yes, you are right. Osteogenesis imperfecta. See, where else is collagen rich? Which layer of eyeball is collagen rich? Sclera. When the collagen is weak, what will happen? Sclera will become thinned out. When sclera becomes thinned out, what will happen? Underlying choroid will shine through the thinned out sclera, making the eye blue. So always think about the pathophysiology of the clinical findings. So defective collagen, thinned out sclera, shining of choroid through the thinned out sclera. You get blue eyes. Bone scintigraphy. What is the agent used for bone scintigraphy? Magnesium 99 NDP. Our NDP model, NDP. Natrium diphosphanate. Bone scintigraphy is used in what all conditions bone scintigraphy can be used among the choices given? Osteoblastoma, especially osteoblastoma when it affects spine or around the hip or pelvis, radiographic demonstration becomes very difficult. So you can demonstrate it by scintigraphy. One of the causes for painful scoliosis is osteoblastoma of the spine. Painful scoliosis in a young child. Alright then. Stress fracture. Stress fracture can be very early detected in scintigraphy than radiography. Radiography takes time or radiography may be misleading. Stress fracture. Battery syndrome. Other names for Battery syndrome? Cafe syndrome. Non-accidental injury, NAI. Non-accidental injury. So, means where the fractures are so subtle, very difficult to demonstrate by radiography, we can go for bone scintigraphy. So what remains is multiple myeloma. What happens in multiple myeloma? For bone scintigraphy to be positive, there should be osteoblastic activity. Alright? Any condition that results in increased osteoblastic activity will be increased alkaline phosphatase. What about multiple myeloma and alkaline phosphatase? In myeloma, alkaline phosphatase is normal. That means there is only osteoclastic activity, no osteoblastic activity. Osteoclastic and osteoblastic activities go side by side normally, except in myeloma. So in myeloma, there is no elevation of alkaline phosphatase. So in the majority, in myeloma, scintigraphy is false negative. Deletion is there but not shown in scintigraphy. So there is a high incidence of false negativity in myeloma. Again, still in myeloma it can be used where there is associated fracture. Example is ribs. Rib lesions of myeloma are usually complicated by fracture. So these lesions can be picked up. So in multiple myeloma, in diagnosed case of multiple myeloma, for follow-up, radiography is more useful, is said to be more useful. You compare with previous radiographs whether new lesions are there or not. So, bone scintigraphy is useful in battered baby syndrome, stress fracture, osteoblastoma, etc. Honda sign is a scintigraphic appearance of stress fracture of sacrum. Will be H-shaped stress fracture of sacrum, commonly seen in osteoporosis or osteomalacia. Honda sign, H sign. Since it is Honda, I will also explain lambda sign. Again in scintigraphy of sarcoidosis. Right paratracheal and bilateral hilar lymph nodes, making the appearance of lambda vertical limb and two lower limb, isn't it? Loss of laminar dura of teeth is upper parathyroidism, alright. So, one of the most useful radiograph in hyperparathyroidism, hand X-ray, phalange. You will look for radial erosion of the middle phalanx of second and third fingers. X-ray hand is the best radiograph for diagnosing hyperparathyroidism. Hyperparathyroidism clinical manifestations are that is well described by disease of bones, stones, abdominal groans and psychic worms. Why abdominal groans? Peptic ulcer, pancreatitis, renal stones, isn't it? Stones, renal stones, nephrocalcinosis, isn't it? Classical skull X-ray finding of hyperparathyroidism is pepper pot skull. What is osteitis fibrosa cystica? Brown tumor. Cleidocranial dysplasia is characterized by supernumerary teeth, delayed dentition is seen in hypothyroidism. Poor dentition in osteogenesis imperfecta. There is associated dentinogenesis imperfecta. Absent teeth in ectodermal dysplasia. Thickened lamina dura in hypoparathyroidism. Absent lamina dura in hyperparathyroidism. This pepper pot skull, fine lucencies in the skull vault. Your answer is Turner, isn't it? No post fitting with turner. If turner choice is not there, we will go for downs. So marker, Down syndrome markers are nuchal form thickening, echogenic cardiac focus, echogenic bowel, dilated renal pelvis, short femur, absent nasal bone. Nuchal translucency normally is less than 3. It is measured between 11 and 14 weeks. Nuchal fold thickness normally is less than 6. It is measured between 20 and 24 weeks of intrauterine life. Generalized lymphangiectasia and cystic hygroma is virtually diagnostic of Turner. Early cystic hygroma and generalized lymphangiectasia in an embryo is around 15 weeks. That is virtually diagnostic of Turner syndrome. Corkscrew esophagus. Is seen it is due to non-propulsive tertiary contractions. So, in which condition non-propulsive tertiary contraction is likely to occur? Is press B esophagus. Press B esophagus. Scleroderma is also a motility disorder characterized by dilated esophagus. Alright? Scleroderma is a disease of smooth muscle. Dermatomyositis is a disease of skeletal muscle. So both conditions result in dysphagia. The difference is dermatomyositis, upper esophagus is affected because only the upper one-third is having skeletal muscle, striated muscle. Lower two-third mainly smooth muscle. Remember physiology of deglutition following: primary peristalsis, secondary peristalsis, tertiary peristalsis. Isn't it? Primary peristalsis starts at the level of cricopharynx. Is a continuation of swallowing process. Is a continuation of swallowing wave initiated by constrictive muscles. Secondary peristalsis is confined to smooth muscle area, so usually lower two-third or starts at the level of aortic arch. Anything that distance esophagus will resulting in a peristaltic wave. If there is any food reflux, even though you are not swallowing, peristalsis will occur because of dilatation of esophagus and body will try to empty esophagus. Alright? Or after swallowing some residual food is there in the esophagus, body will sense and it will try to empty that by secondary peristalsis. Tertiary peristalsis is non-propagative, uncoordinated contraction. This occurs in older age group, press B esophagus. This is a motility disorder. Contractions are there, they are not coordinated. There is no forward movement, only to and fro movement. Nutcracker esophagus can be diagnosed by esophageal manometry, not by barium studies. Nutcracker esophagus is diagnosed by esophageal manometry. Esophageal manometry is also used to diagnose reflux disease, GERD, gastroesophageal reflux disease. Rectal manometry is used in the diagnosis of Hirschsprung's disease. Feline esophagus, like a cat. That group, that genus feline, is said to have transverse mucosal folds in the esophagus. So some human beings with that feature. It is not of pathological importance, simply maybe an incidental finding in barium studies is known as feline esophagus. It is corkscrew esophagus. MR is not useful in diagnosis of acute subarachnoid bleed, because subarachnoid bleed is occurring to CSF, which is got very high oxygen tension. Oxyhemoglobin is insensitive to MR. There is no different signals. So, subarachnoid bleed is difficult to diagnose by MR. All other conditions can be easily diagnosed. So, in subarachnoid bleed, investigation choice is CT. If CT is negative, still suspecting subarachnoid, we will go for lumbar puncture. Commonest cause of spontaneous subarachnoid bleed is rupture of aneurysm, rupture of body aneurysm. AVMs most commonly result in intraparenchymal hemorrhage. That is subarachnoid hemorrhage. Basilar invagination is not seen in I will explain the term basilar invagination. The normal posterior fossa has got a slow slanting slope towards the foramen magnum, like a funnel. Not very steep, but it is always towards foramen magnum. When the base of skull becomes very soft, because of the weight of the head and brain, this bone becomes invaginated into the cranial cavity. Got it? What is meant by basilar invagination? There are some pathological conditions where bone becomes soft, means it becomes gradually remodeled. It gradually goes in, invaginates. It gradually invaginates. Bone softening conditions are 1. Osteogenesis imperfecta. 2. Softening, malacia, bone, osteomalacia. Okay? Myelomalacia, softening of cord, isn't it? Spinal cord. Osteomalacia, bone softening. Encephalomalacia, brain softening, isn't it? Osteomalacia. 3. Fibrous dysplasia. 4. Page's disease. So in all these conditions, you can get basilar invagination. So osteomalacia, fibrous dysplasia, and Page's disease. In Page's, bone is thickened, but it is weak. Fibrous dysplasia, again it is thickened, but it is weak. Basilar invagination is not not seen in achondroplasia. In fact, in achondroplasia, skull base is narrow, so that you can get obstruction of the foramen magnum level. The resultant hydrocephalus. Severe achondroplasia may result in hydrocephalus. So all bone softening conditions will also result in central migration of the femoral head. This is known as protrusio acetabulae. When the femoral head gradually migrates centrally and the floor of the acetabulum bulges inwards, this condition radiographically is known as protrusio acetabulae. This is also manifestation of the above said bone softening conditions. Opposites, fiber dysplasia, osteomalacia and osteogenesis imperfecta. So radiology of osteomalacia, codfish vertebra, milkman's fracture. Where does this milkman fracture occur? It is nothing to do with milk or man or phalanges or hand grip. Person named milkman, radiologist named milkman, 1934, discovered this. This is nothing but pseudo-fracture, also known as milkman's fracture. Somebody answered that by holding the milk pot between the femur, between the thighs, and it is fracture of femur, or somebody imagining that it is occurs in the phalanges or metacarpals, the milkman's fracture. Codfish vertebra, milkman's fracture. Protrusion acetabula, basilar invagination. You can take down this and then you will finish here. Open mouth is for craniovertebral junction and evaluation of C1 and C2. Foggy means in diagnosing purpose and vascular necrosis of femoral head. When you have bilateral hip raised view is for epiforamen. Node is very rarely employed because of safety and all, but if question comes, you can know. Transfer for internal herniatus, rib hump view for scoliosis, Barlow's projection is congenital dislocation of hip, or present terminology is DDH, developmental dysplasia of hip. Stenosis is for petrous apex. Orthosis is for PMS. We will continue in another session. Alright? So that is C1, C2.